Okay.
I'm sorry, Evelyn's name is wrong on the OrthoTV poster. So this is correct. We will fix this later when it gets published.
Is this a live broadcast or we are recording it this right now?
Okay, we are online.
So with permission of our Vice President, Dr. Christian, I would like to start the session. Yes, it's a live one, but we are recording it also. Okay. So good afternoon, everyone. I am Dr. Quazi Shahid-ul from Bangladesh. I am Dr. Quazi Shahid-ul from Bangladesh as the chair of the session, welcoming and inviting you all for today's talk on pediatric fractures and its pitfalls. It's an academic initiative organized by the Asia Pacific Trauma Society. This is the first upward trauma online session on advanced topics on orthopedic trauma, and more are yet to come, which will be notified to you all with time. Today we have Dr. Anup Agrawal, President of Executive Committee of Asia Pacific Trauma Society, along with Vice President Dr. Christian Fang with us from Hong Kong. We also have Dr. Ayesha Saeed as a panelist from Pakistan for panel discussion moderation, and our Professor Sarwar Ibne Salam from Bangladesh as a moderation of the webinar. We have three speakers, from India, Dr. Sandeep Patwardhan, then Dr. Evelyn Kuong from Hong Kong, and Dr. Kyeong Hyeon Park from South Korea. So they will be presenting all the three topics that were enlisted today. So without any further delay, I would ask Dr. Professor Sarwar Ibne Salam to conduct the session on pediatric fractures and its pitfalls. To Professor Sarwar Ibne Salam.
Good afternoon, everyone. So this is a very true Asian thing, as Eastern from Evelyn Kuong is probably from far east, and Dr. Ayesha Saeed is from far west. So let us go start. Our first speaker is today Dr. Sandeep Patwardhan from Pune, India, with translations. Dr. Sandeep Patwardhan.
Good morning, this is Dr. Sandeep Patwardhan, and I'm here today to talk to you about the enigmatic elbow. Very often we find that when we see a child, it's always an enigma when the child has a fall on his hand. The elbow is swollen, it's painful and stiff, and you get an X-ray done. And the X-ray in your mind seems to have only two diagnoses, either a supracondylar displaced fracture or a type 3 lateral condyle, which are by far the most commonest elbow injuries that you get in the pediatric age group. Supracondylar accounts for 75% of these cases, and lateral condyle is about 17%. But that just makes it 92%. 8% of the elbow injuries are osteochondral fractures, which are commonly missed. So the eyes don't see what a mind does not know. And my job here is to make your mind aware or open about the other injuries which are dismissed commonly as trash lesions. What is a trash lesion? A trash lesion is a swollen elbow with an innocuous or near normal looking X-ray which might be thrown away in the dustbin thinking it's trash. But these are the injuries which will always need some kind of surgical intervention. And if you don't diagnose them right, they have serious long-term complications. Let us look at some cases. This is a 9-year-old boy who came to me about 3 weeks after injury. This was his X-ray. Elbow was swollen, painful, and he had restricted extension. And initially, he was treated by a surgeon who told him that the X-ray is normal and was sent away. Now, on further investigations and drawing some lines, I found that the radial head was subluxated posteriorly. The CT scan revealed that there was an anterior head osteochondral fracture with a progressive posterior subluxation of the radial shaft along with the remaining head. And that was his intraoperative picture. So he had to undergo an open reduction for this radial head osteochondral fracture. After open reduction, we had to put a Herbert screw to restore the article congruity and reduce the shaft of the elbow and the remaining head back to its normal position. That was the intra-op video. And this was his post-operative imaging. That's his function at 3 months down the line. His pain has gone, the stiffness is gone, and he's back to his passion, which was boxing. And 5 years down the line, this young child is now a national level boxer, and we have removed his screw and he's just doing fine. So this was an interesting trash lesion that you should be aware of. Another case, a 3-year-old with a swollen elbow with restricted supination. X-ray looks pretty innocuous, but additional imaging in the form of an MRI shows that it's a radial neck fracture with a completely unossified radial head. And you can see the star which shows you that the head is lying outside the joint. So it's a complete dislocation through the epiphysis of the radial neck. Now this will not be seen because on an X-ray, the ossific nucleus of the radial head does not appear till about 4 years of age. So radial neck fracture dislocation is another osteochondral lesion, also can be missed and you should be aware of. Now a 5-year-old, you can see this X-ray. Child had a swollen elbow, a small bit of bone there, and this was diagnosed by somebody as a medial epicondyle fracture. They took the comparative X-ray on the opposite side and found that the medial epicondyle, which should be in the normal position, seems to be displaced. There is an option of treating medial epicondylar fractures conservatively, so this child was given a slab and sent home. This is what happened. But 2 months or 3 months down the line, the child was no better. He had a stiff elbow, he had pain, and you can see on the plain X-ray now there seems to be some calcification or ossification which is happening on the medial side. And eventually, this metaphyseal ossification suggests that the true diagnosis is a medial condyle fracture, not an epicondyle fracture. Like you have lateral condyle, the entire medial condyle can break and rotate along with the flexor origin with a little bit of metaphyseal bone. And that metaphyseal bone may be mistaken as epicondylar fracture because the rest of the medial condyle at that age is completely cartilaginous. So medial epicondyle fractures are unusual in 5-year-olds. This ended up with a very bad cubitus varus and a stiff elbow with a flexion deformity like this, which could have been avoided. This was poor result. Another example, this is another X-ray with a swollen elbow. Always look at the medial soft tissue shadow. You can see a large soft tissue shadow with a small bony fragment, and an arthrogram may be able to confirm the presence of a large condylar fragment, which then needs to be open, reduced, and fixed like you do with the lateral condyle. 5-year-old, fall on outstretched hand, large swelling on the medial side, small flake of bone, and MRI shows you that the entire medial condyle is lying outside. So have a very low threshold for getting further investigations done in the form of arthrography or MRI when you see such a lesion. The key point to remember is medial epicondyle fractures before age of 9 should be considered as medial condylar fractures unless you can prove them otherwise with additional imaging. The fourth case, this child was treated as an elbow dislocation. As you can see, the both radius and ulna are subluxed on the medial side. But what is the true diagnosis? The true diagnosis is a transfacial separation. Very young children or neonates, commonly mistaken diagnosis of elbow dislocation is made. How can you avoid this pitfall? Make sure that the radius and ulna are together, they are aligned to the capitulum, and they move posteromedially. The elbow dislocation moves laterally, whereas the transfacial separation moves medially. And you need to treat it like a supracondylar with reduction and arthrography and a couple of pins to hold the fragments in position. So this is how it was done. Just to recapitulate, a normal elbow alignment, in an elbow dislocation, ulna and radius will go posterolateral. Lateral condyle, the radiocapitular line is disturbed and the fragment rotates. In supracondylar, the alignments are maintained and the fracture is in the metaphysis. But in a transfacial separation, you will see that it goes posteromedially and you may not be able to see the distal humeral physis, which is cartilaginous. Case 5. Here you can see that the elbow is swollen. And just look at the X-ray. It looks very innocuous. It seems as if there is no fracture. And this ultimately came after 4 weeks with a bad cubitus varus and a malunited Montegia, proximal ulnar fracture. And if you revisit the old X-ray, now you can see a small crack which was going in the proximal ulna, which was missed and ultimately was undertreated with a plaster and it displaced into a bad cubitus varus. This is a 10-year-old. Now you are seeing an older child and you can see that medial epicondyle is avulsed with soft tissue swelling there. Now medial epicondyle avulsion can be treated conservatively, but with wide displacement and the flexor origin attachment, especially in high demand young children with instability, it would be a good idea to fix it with a compression screw or a suture anchor. Sometimes this fracture also exists with fracture dislocation of the elbow. So if there is instability with medial epicondyle fracture, open reduction with a cannulated cancellous screw fixation will restore function to normalcy. Another example, 1 month post-injury, child was treated for an elbow dislocation, swollen elbow, stiff elbow. And what can you see? On the medial side, you can see that the epicondyle is missing, but you can see interarticular ossification there on the trochlear side. So you should be immediately suspicious that this elbow dislocation has a incarcerated medial epicondylar fragment. So an elbow dislocation, when it is reduced, there is a risk that the medial epicondyle with the ulnar collateral ligament can flip over and get incarcerated into the joint and can commonly be missed. And that will lead to a very bad outcome. So do not miss an incarceration. Get additional investigations like an MRI or a CT scan, remove the trapped fragment, reposition and fix it. Sometimes you have to excise it and do an arthrolysis to restore the elbow function. So this is what you can see in this picture. Even the ulnar nerve has got interposed and that was removed. The fragment was restored and a fixation was done so that the neuropraxia went away and the elbow stability was restored. Another case, a medial epicondylar fracture dislocation, reduction, and this child open reduction with cancellous screw fixation with a wire. Sometimes people have tried closed reduction followed by plaster and you can get healing, but the elbow may remain slightly weak. Another example, an innocuous looking X-ray with a painful swollen elbow. The X-ray shows on the lateral a small lateral condylar fracture which is undisplaced. This is commonly treated with a slab, but at 4 weeks you can see that the fracture line has actually increased and you can see more lucency. And at 7 years, a complete frank non-linear. So what happened here? Now you must realize that never consider a lateral condyle fracture heal unless you can demonstrate osseous union. And the second message is the stage 1 of lateral condyle fracture has to be subclassified into type A or type B. And what is type A? Type A is where the medial cartilaginous hinge is intact. I'll show you some examples. Look at this X-ray. The metaphyseal crack is completely visible. But we have no idea where is the exit line of this fracture through the cartilage. Is it stopping short or is it going across into the joint and the cartilage is broken? Now this child was treated in a plaster and you can see it displaced and went into non-union. So this was a complete fracture through the cartilage which got displaced because of the extensor apparatus pulling out the lateral epicondylar region. Now another example, this child you can see that there seems to be a malposition of the lateral condyle with a large soft tissue swelling. Now, an arthrogram was done and it was confirmed that there was a completely rotated lateral condyle. And then it was properly treated with close reduction and K-wire fixation. So there's always this dilemma, a type 1 lateral condyle, should I fix it or should I trash it? Okay, and how do you identify? You investigate. What are the investigations? An MRI. MRI shows you in this particular case that the cartilage hinge is intact and this is type A, which is stable and can be conserved and goes on to a nice healing. But a similar looking X-ray on the metaphyseal side shows you on MRI that the cartilage hinge is broken. Now what happens is that within a week, synovial fluid leaks into the fracture, the hematoma is diluted, and the extensor muscles are pulling this fragment apart. So when the plaster becomes loose in a week, the fragment displaces, and this will not heal and goes into non-healing. Dynamic examination with an arthrogram is always useful. You can see the gap opening up on varus stress, and this needs to be fixed with a K-wire to prevent this complication from happening. Another case, an adolescent child, innocuous looking X-ray, swollen, was treated in a plaster, came back with a painful stiff elbow. A true dead lateral taken at 4 weeks shows you a shear fracture of the capitulum. The CT scan confirms that this was a shear fracture of the capitulum, which was open reduced and fixed with Herbert screws, and the articular congruity is thus restored. Another trash lesion, a 9-year-old national swimmer who had posterolateral instability on doing backstroke. X-ray looked innocuous. Doesn't seem to be anything wrong on the plain X-ray. But if you look closely on the lateral X-ray, there seems to be a small avulsion behind the lateral condyle. And further investigations like an MRI showed that this was a sleeve fracture. So an osteochondral posterior capsular sleeve fracture of the lateral condyle. And this was connected to the capsule and the radial head used to subluxate because this was not healed up. So we had to open reduce, freshen the edges and fix this with Herbert screws so that we tightened up the posterolateral corner, and this healed in 3 to 6 weeks and the child is back to normal state. So what are these trash lesions? This is a group of osteochondral injuries which, if treated insufficiently, always result in chronic long-term consequences. A prompt diagnosis and a high level of suspicion with early additional imaging is mandatory. All of them are displaced and unstable. They require anatomic reduction and internal fixation with soft tissue diffraction. Additional imaging in the form of ultrasound, which is inexpensive, or an MRI or an arthrogram as per your availability should be used to diagnose these lesions. Don't trash a swollen elbow in a child. Remember that supracondylar fractures and lateral condyle are not the only injuries around the elbow. Use additional investigations as per availability, affordability, and your experience. And always be ready for surgical intervention. We have published our series of trash lesions, a review of approach to diagnosis and management in the Indian Journal of Orthopaedics in 2021. It would be worthwhile to go through this paper. Original paper by Peter Waters and James Castle from JPO 2010, where they have given a list of the trash lesions: osteochondral fractures with joint incongruity, radial head compression fractures with subluxation, Monteggia variations with subluxation, lateral condyle avulsion or shear fractures, non-ossified medial condylar fractures, transfacial separations, trapped epicondylar fractures, and complex fracture dislocations. Please remember the ossific centers around the elbow and when they appear and when they fuse so that you don't miss these osteochondral lesions. The mnemonic credo everybody knows: lateral condyle at 1 year, medial epicondyle at 5 years, radial head at 3 years, the trochlea at 7 years, and lateral epicondyle which comes at 11 years. So now that you know these trash lesions, please make sure that you don't trash a swollen elbow with an innocuous looking X-ray, and make sure that you diagnose them correctly. Thank you very much, and I'll be happy to answer any questions.
So thank you, Sandeep Patwardhan. That is a great paper.
Thanks.
I don't find any question anywhere. So should we be discussing inside? We all can ask questions or what?
Yeah, most welcome.
Actually, we have around 10 minutes for each speaker to discuss. So should we be discussing or any questions would come from anywhere? Dr. Anup is there?
I will convey the questions as they come up. Till that time, you and Dr. Ayesha Saeed can proceed the discussion, sir.
Okay, Dr. Ayesha Saeed.
So I have a question.
Yes.
Yeah, I have a question, Dr. Sandeep. So really interesting cases and the very subtle things that are easily missed. So my question to you is regarding the transphysial separation. So mostly it's seen in few days old neonates, and most like in my practice lifespan, I've seen 3 such cases, and all of them were more than 10 days old. Yeah. So at that particular point in time, every time the discussion was either it would really be worth, opening this fracture and aligning it in a neonate where we think that it's going to remodel greatly. So what's your take on that?
Yeah, great question, Ayesha. I hope you can hear me. Am I audible? Yeah. Okay. So as you rightly pointed out, it's very often during delivery or immediately after delivery that a referral is made for a swollen elbow in a neonate. And it's usually a week or 10 days old. Already time has passed and it's glued up. So doing an open reduction in such a young baby is not at all indicated. As you said, the growth potential is tremendous. And compared to a normal supracondylar malunion, this remodels pretty fast and pretty well. So we would not do any kind of intervention other than pain management with a small splint for another 10 days or so and wait for remodeling. But those that do not remodel, we will be in a better position to counsel the family that an corrective osteotomy might be needed if it does not remodel well. The second thing is, less than 2 years, you can have a Salter-Harris type 2 low supracondylar with a small Holland fragment which mimics a transphysion. Again, that can be missed because of not being visible on a plain X-ray. So the thing is, if your radius and ulna proximally are moving congruously towards the medial side, you are more likely to be seeing a transphysial separation and not an elbow dislocation. So those kids who are less than 2 years with a Salter 2 low supracondylar will be mimicking a transphysial separation. So those are the ones which need to be diagnosed and reduced and pinned so that you don't end up with a malunion. The neonatal transphysials, as you rightly said, are usually delayed presentations. And we would treat them later with an osteotomy. Very rarely will you get a fresh referral. Does that answer your question?
Yes. Yeah, that certainly does. Thank you.
All right. Yeah.
Sandeep, one question.
Yes.
90% of elbow injuries, 1992, that either these are supracondylar and lateral condylar.
Yes.
We are used to manage those cases.
Yes.
And these 8-10% cases are we do not see in normal X-rays, traditional X-rays.
Yes.
What should we do? What you do? Do you in these cases send for MRI on the day 1 or 2 or wait?
Yeah. So that's a great question because we all are from a Southeast Asian region where we are in a resource limited environment very often, and we may not be having access to all the advanced modalities. But the idea of the paper and the presentation is that if you do not see a supracondylar or lateral condyle and you still have a swollen elbow, it's your job to rule out an osteochondral injury because, as you saw, all of them are osteochondral fractures which need surgery. They cannot be conserved, right? So you might have to develop expertise in your region, and you have 3 modalities available. If you have a good sonologist who can look at the cartilage, that would be the best because it's inexpensive, cheap, and dynamic. But again, there will be a learning curve for your radiologist to look at cartilage lesions in a very small. And you should be able to provide him inputs clinically as what you are suspecting, depending on where the soft tissue swelling. So pay attention to the soft tissue swelling and ask him to look for specific things, and he might be able to help. If the child needs is in an urban situation, like I practice in Pune, which is an urban city with facilities which are easily available, and we have very high demanding parents. So in those situations, you can get an MRI done, but that involves sedation. Some kind of sedation is required. So if you are pretty confident with your clinical diagnosis, then you can also opt to do an arthrogram which involves ketamine or sedation, and you can keep the lesion simultaneously. So the option between doing an MRI for diagnosis or doing a short anesthetic with an arthrogram where it is diagnostic as well as therapy depends on your facility available and your expertise and circumstances. So have a high index of suspicion. Don't trash the X-ray saying nothing is wrong and send it right away. Call him back and use one of these three modalities, either an ultrasound or an MRI or arthrogram, depending on your learning curve as well.
Thank you. Thank you, Sandeep. We have two questions from the chairman, yes. But you have already answered the first one, I think. But what about the second one? Can you fix all lateral condyle as soon as it is diagnosed, not taking conservative options?
Yes. So
lateral condyle.
Yes, that is one of the interesting questions. But we have Professor Song's article, which we are all following from Korea, where he has classified the lateral condyle fracture now into 5 types. And using his classification, if you are able to see if the gap at day 0 and day 5 is increasing, I would not rely on one X-ray. You do see an undisplaced type 1, day 1 on an internal oblique. You give a slab, you call him back in 5 days. And in 5 days, you take another X-ray without plaster in the same internal oblique. And if you find the gap medially as well as laterally is increasing, then you are reasonably sure that cartilage hinge is broken and it's unstable. And then at day 5, fixing it does not lead to a bad result. So you can do the delayed fixation so that you don't over-treat and fix every kid with a type 1, right? So the answer is not go around putting pills in every child. It's important to give a conservative treatment, but it's important that the conservative treatment involves a very meticulous follow-up at 5 days, 10 days. And if you find it displacing, you can still reduce and pin it, and the outcomes are just as good. Right? And if you have facility, an arthrogram will help.
I actually have a few comments about the X-ray for the lateral condyle fracture.
Go right ahead, Evelyn.
The lateral condyle fracture is often posterolateral, which means on a true AP and a true lateral, you actually don't see the fracture line. So when I examine the child and I'm convinced that there is tenderness on the lateral side of the elbow, and I don't see any clear fracture line on the AP or lateral, one good trick is to repeat the X-ray of the elbow, but with the elbow in slight internal rotation. It's usually described as about 30 degrees. So if you take the AP view, but just internal rotate the elbow by 30 degrees, often you will see the fracture line. That's where the fragment is because it's posterolateral. And so you're right. I actually don't do MRIs myself either because it involves sedation. And so at most I will do an X-ray, repeat an X-ray in internal rotation of 30 degrees. And if not, I will actually just go in for an arthrogram. So that's how I do it.
Yeah.
Okay, Evelyn, what about you say about that second question? Can we fix all lateral condyle as soon as it is diagnosed? As already Sandeep said. So what is your say about this thing?
So there are different types of lateral condyle fractures. Some fractures, after investigations, you find that they are really undisplaced or very minimally displaced within 2 millimeters, depending on the age of the child. And in those cases, I do apply a plaster which has to be a full circumferential, not a back slab plaster. And I follow them weekly because we know that lateral condyle fractures, which initially may not be displaced, they have a high incidence of displacement subsequently. And so for undisplaced lateral condyle fractures, I put on a complete long arm plaster, and then I counsel the parents that they need weekly x-rays. And at any time I see displacement of the fracture, then we go in for closed reduction, plus or minus open reduction, and pinning.
Okay, thank you. 30 minutes gone for the first speaker. I think we can go for the second. Dr. Ayesha, Saeed, would you moderate this part of the talk? Please go on.
Yes, of course, of course.
Please. The next speaker will be Dr. Evelyn Kuong. Please go on, Dr. Ayesha Siddiq. Ayesha Saeed, sorry.
Yeah. So I'll invite Evelyn. She's going to present live on a very challenging situation, which is a pediatric hip fracture. So let's hear more from her.
So, greetings from Hong Kong. I come from Hong Kong Children's Hospital, and I will talk to you today about pediatric hip fractures. Thankfully, it is a very rare entity. In fact, pediatric hip fractures only occur when this very tough periosteum is disrupted and torn, which in children, the periosteum is very thick. And unfortunately for them, though, the proximal femur remains cartilaginous for a very long period of time. So once this periosteum is torn, then the underlying cartilage can be easily fractured. But always this requires a high energy trauma for this to happen. And because they are always due to high energy traumas, you also have to look for associated injuries, which has a very high prevalence rate of up to 85%. So these are usually multiply injured children with femoral shaft pelvic fractures. Always do the ABCs and follow the ATLS protocol. In the non-walking age child, and you have a lower limb fracture, always look out for non-accidental injuries. If it is genuinely a low energy trauma, you have to look for pathological fractures. Usually, if you can get a fracture through the proximal femur, but it is a low energy, it must be something wrong with the underlying bones, such as a bone cyst, tumors, or even infections. So you have to work them up accordingly. X-rays include AP X-rays, cross-table laterals, and always take an X-ray of the contralateral side for comparison because sometimes the fracture can be quite hard to see on just one view. If your institution has this and the MRIs are available, this is helpful for children who are very young where the proximal femur is still very cartilaginous. But oftentimes an arthrogram is probably what you'll have to deal with. The reason why pediatric hip fractures are so terrifying to pediatric orthopedic surgeons is because the blood supply to the epiphysis is very tenuous. At birth, when the physeal plate is not yet well formed, then the femoral head is supplied by the nutrient arteries that go up to the metaphysis and supply the head. But by about 3 years of life, this cartilage plate is very mature. And therefore, the circulation to the epiphysis is only from these ascending branches from the lateral cervical ascending artery, which is a branch from the medial circumflex artery, which is why the rate of AVN is so high. When we talk about pediatric hip fractures, we usually use the Delbay classification, and much of what I will talk to in the next few minutes will come from this great review paper, which I urge you all to read from 2019. Now, Delbay 1 is a transphyseal fracture, which means it fractures through this cartilaginous physeal plate here. Again, it is always due to high energy trauma, and the outcome of these, because it is intra-articular and disrupts the ascending arteries, is quite dismal. Almost 100% of them have AV and physeal arrest. In neonates, when the femoral head is completely cartilaginous, all you see sometimes is just a high riding metaphysis, and it's unclear whether it's a dislocation or a fracture, but an arthrogram will tell you the answer. If they are very young and undisplaced, and you are convinced that you've got a good reduction, you can simply place them in a hip spica. But if they are displaced, then you really do need to do a closed reduction. Now, a closed reduction of a femoral neck fracture in an infant is the same as in an adult. You have to flex, abduct, and external rotate to counter the deforming forces of the abductors of the hip, the gluteus medius, and also the iliopsoas muscles. After that, in a young child, you want to pin them with smooth pins and then further immobilize them in a hip spica in the human position, which is with the hip flexed, abducted, and in neutral rotation. If they're older than 2 years of age, often you will need an open reduction. So prepare this when you talk to the parents. I like to do this approach, which is a lateral approach to the proximal femur. You detach the abductor mechanism, and then you can open the joint anteriorly. So it's an anterior arthrotomy where you visualize your reduction, and then you shoot your fixation in from the lateral side, either with smooth pins or with cannulated screws. When you get to 1B, this is the worst outcome. Not only is it a transphyseal fracture, but the epiphysis has dislocated out of the acetabulum. And as you can see from this report from the Koreans, the outcome of AVN is almost 100%. And this went on to require a vascularized fibular graft. It's not perfect, and this child will probably need an arthroplasty in the future. When you get to Delbay 2, it's a transcervical fracture, and Delbay 3 is a base of neck fracture. The AVN rate starts to drop, and the risk of physeal arrest also starts to decrease. Both of these fractures are usually treated in the same manner. Closed reduction. If it's not an anatomical reduction, please proceed to open reduction and then fix it well with screws. If you have enough space in the proximal femur, then by all means spare the physis and have the screws stop short of your physis. But if you feel that you don't have enough space in the metaphysis, then by all means feel free to go through the physis and enter the femoral head with your screws. Yes, you will induce a physeal arrest, and the child will later end up with a leg-like discrepancy, but a limb-like discrepancy is much easily treated than a poorly fixed neck of femur fracture that then goes into non-union, malunion, and then avascular necrosis. So be wary of how many times you try to do the closed reduction. If the closed reduction does not work, proceed to open reduction. No point in wrestling with it. Finally, as you see in adults, capsular decompression does not have a very strong statistical significance in reducing AVN, but there really is no harm done, and I personally always do it. And so with Delbay 3 fractures, you have the luxury of having more space in the neck for your fixation, but remember, AVN can still sometimes happen, as you can see from our patient from a long time ago. Finally, Delbay 4 is an intertrochanteric fracture, and the AVN rate and the physeal arrest rate is only occasional, and there are only sporadic case reports for those. For these patients, you can do a pediatric sliding hip screw, or nowadays we have a lot of pediatric size locking hip plates. The most dreaded complication for pediatric hip fractures is really avascular necrosis. And of course, anatomically, you would expect the highest rate of AVN from types Delbay 1 to 2. There are studies that show that the older the child, the more likely they are going to develop AVN. Maybe it's because the younger child has a higher ability to revascularize or remodel the femoral head. Nobody's really sure. And then the meta-analysis also shows that surgically managed hip fractures also have a higher rate of AVN. This may just be a selection bias. Those who require surgery are likely to be more severe injuries or from a higher energy trauma. And what is universal is that those who are treated at a later date, after 24 hours, have a higher rate of AVN. So at least in our institution, neck of femur fractures in children, as it is in adults, is an emergency, and we try to treat them within 24 hours. Now, displacement is a funny thing. There are some papers that show that high energy trauma that causes displacement have a slightly lower rate of AVN. This may just be because they have ruptured through the capsule and they now no longer have a high intra-articular pressure, and therefore it's done the capsulotomy for you, and that's why they have a slightly protective way of reducing AVN. But I wouldn't count on displacement as whether or not you do a capsulotomy. I would always do a capsulotomy anyway. And so how you do a capsulotomy is entirely up to you. I use scissors, a sharp medicine balm to poke into the joint capsule. Another center from Hong Kong as well, they do aspiration. So they insert a wide bore needle and aspirate the joint hematoma. Both ways work. What you just want to do is decompress the joint capsule. Now, when you talk about established AVN, of course, those with a diffuse involvement of the femoral head have the worst prognosis. If you do, unfortunately, encounter avascular necrosis, you treat what you can. You provide protective weight bearing, remove the fixation devices. If the head has not collapsed fully yet, you can do vascularized fibular grafts. But salvage therapies include hip fusion or wait for the child to be old enough for a hip arthroplasty. Another complication is physeal closure. Again, if the fracture is very close to the physis, this can happen, but sometimes it's iatrogenic. It's simply because you pass the screws through the physis and you've induced this. But to me, this is a much lower in priority because I can always fix the discrepancy, no matter how much it is. Things like coxa vara are closely linked to non-union. We find that non-union cases typically go into a varus alignment. It's very, very uncommon, but I was asked to talk about this as well, and I found a nice paper that talks about the treatment of established non-union of pediatric femoral neck fractures, which typically look like this, go into coxa vara. And what you do is almost like what you do for congenital coxa vara cases. The congenital coxa vara cases are treated with a valgus osteotomy called a Powell's osteotomy, which is a Y-shaped osteotomy. This paper, the authors here called it a modified Powell's, but it's the same idea. What you want to do is you want to remove this vertical shear force of this neck of femur fracture and make it more horizontal. And the only way to do that after you reduce the femoral head is to do a valgus osteotomy. And you do the valgus osteotomy by taking away a triangular wedge from the lateral side of the proximal femur. And when you do that, you actually reduce, for example, in this diagram, a fracture line, which is originally 45 degrees with a horizontal. And when you do a valgus osteotomy, you bring it down to 25. And this is exactly what you would do for congenital coxa vara cases. I would actually aim for 20 or less, but 25 to these authors seems to be appropriate. What is interesting is that in this series of 10 cases, none of the patients received a bone graft. So none of these fractures were actually opened up and bone graft was applied. It seems that all you have to do is put a pin in that reconnects the femur with the greater trochanter and then do the valgus osteotomy. Just by converting the vertical shear stress to a more horizontal fracture line, it will actually heal up quite well. Of course, if you can apply interfragmentary compression with the screw, then that is always best. So in conclusion, beware of Delbay 1. It can look like a hip dislocation. You might sometimes need an MRI or an arthrogram. If they are young, treat them with smooth pins and a hip spica. For the other neck of femur fractures, always do anatomical reduction. This is the same as you would in adults. If closed reduction doesn't work, then go for open reduction. And the open reduction should be done through an anterior approach. You want to aim for stable internal fixation, which means smooth pins if you can, but cross the physis with screws if that's what it takes to have a smooth, stable fixation. And then I always do a capsulotomy to reduce the AVN rate. Finally, in terms of non-union, the idea is non-union typically leads to coxa vara. And if you want it to unite, you have to reduce the fracture first and then do a valgus osteotomy. Bring the fracture line to 25 degrees or less to the horizontal, like they did here, and then fix it stably with either a blade plate or interfragmentary compression. Thank you, and I welcome any questions.
Thank you very much, Evelyn. That was a great review on a rather quite a challenging situation. So I'll first invite questions from the participants, if there are any. And otherwise, we can the panelists can go ahead with their own queries or comments. So I don't see any questions.
Let us ask the other speakers to speak out. Other speakers,
also not on the OrthoTV channel.
Dr. Asha, we can ask the other speakers. They can also ask Dr. Sandeep, Dr. Kuong.
Hello?
Yes, please.
Yeah, can I ask you a question?
Sure.
Okay. So, what is your opinion on the role of intraosseous bisphosphonate injections for acute AV and post-fracture?
I couldn't hear much of your question. What is the role of
intraosseous bisphosphonate injection to prevent the head from collapsing for treating AV and post-fixation?
So the question is, what is my view on intraosseous injection of bisphosphonates in the setting of established avascular necrosis of the femoral head prior to collapse. And yes. I don't do it myself. I have no experience there. I am aware that people have tried it. It's almost like what they're trying for Perthes disease, but I don't do it myself. So I have no opinion on that. I suppose there's no harm done. I might try it, watch for a couple of months, and if I don't see any improvement, maybe in 3 to 6 months, I would try something else.
Okay, so
what do you do, Sandeep?
Evelyn,
Sandeep,
there are some questions from the.
We can ask Dr. Sandeep. What is your say about this intraosseous thing?
Yeah.
No, so like most of the time when there would be some kind of deformation of the head. So when the patient is coming for implant removal, that is the time we use the whole of the screw or the implant itself to instill artificial bisphosphonated. We have found that it retards the rate of collapse by inhibiting the osteoclastic activity. Keep the child non-weight bearing for about 3 to 6 months. And once the head is reconstructed, we can do a safe surgical dislocation approach and reshape the head. And even pretty decent results in a few cases that we've done it. So it's an interesting new way of trying to salvage the hip in young adolescents rather than going for hip.
Oh, thank you. I'll try that next time when I take the screws out.
I think Anup has a question.
Yeah.
So may I ask one question?
Yes, please.
Sure.
There are some questions in the chat as well. So,
please go on with the chat questions. Please go on with that. I'll ask later on.
No. Please, we can go ahead with them after.
Dr. Evelyn, my question is: we have seen you say you did conservative treatments with spikers and sometimes surgeries. Do you ever have to use a spiker or something like that even after fixation of the fractures, like say type 1, 2, or whatever?
The hip spica is additional. The hip spica is to enhance your immobilization. So for the fractures that you only fixed with smooth pins or K wires, always hold with a hip spica. Occasionally, I even put them in a hip spica after I put in screws. But that's for the very young child, the very uncooperative child, the autistic child, the mentally disabled child who will not follow commands and cannot be controlled by parents. I will put them in a hip spica. The hip spica is only to help your immobilization. So it depends on what you put inside the child. So if it's displaced and you had to reduce it because it's very young and it's a very small child, you only put in K wires, smooth wires, because you don't want to cause limb discrepancy due to physial closure, then you always put in a hip spica. It really depends on the child and how well you need to immobilize them.
Thank you.
Yeah. Okay. So there are some questions in the chat, Evelyn. The first one is, I think the person is trying to ask if there is ever a possibility of conservatively managing these kind of fractures in very, very young patients.
So if you read the books, undisplaced fractures can clearly be treated with hip spica. But personally, I've never seen a genuinely undisplaced neck of femur fracture. This may be the very, very young, the neonate, the one that you diagnosed on arthrogram. Yes, so theoretically, yes, there is a role for conservative, meaning no internal fixation, just hip spica. Personally, I have not encountered it. And in my experience, even the very young ones, they are displaced. I would reduce them, fix them with smooth pins, and put them in a hip spica. I rarely don't put any hardware inside.
Okay. So Dr. Anup has a question. Let's go to his question first. And then I believe we have a few minutes for the other chat questions as well.
Thanks, Ayesha. Sorry for joining late. My question is there any difference in incidence of ABN if you
Sorry, I missed the second half of your question. Is there any difference in AVN between
doing a needle aspiration vis-a-vis doing a capsulotomy by a Caesar?
Yeah, that's a great question. In fact, the paper I showed you, also from Hong Kong, but from Chinese University, they, to this day, still do needle aspirations. They put in a wide bore needle and they aspirate it. In our center, I like to put in the scissors and cut it. I don't believe that there are any studies that show one way of capsulotomy is better than the other. The key is to do an adequate capsulotomy. You really do have to decompress. So, for example, when I put my scissors in, I really have to put it through the capsule, spread the scissors, open them up, and be convinced that there is a gush of joint effusion coming out before I'm happy that I've actually done one. But you're right. With a joint aspiration with a wide bore needle, it may be more accurate in the sense that you can actually see the effusion. You can actually see the joint fluid coming out into your needle. So it might be a bit easier to confirm that you've actually done one. But I don't think there are studies that show one is better than the other.
Thank you.
Okay, so if there's still, I believe we still have 5 minutes.
Can I make a comment regarding AVN?
Please go on, Sandeep. Any comments?
Yeah, just to add to the discussion what Anup asked, capsulotomy has not shown to be very conclusively effective in reducing AVN rates. So first thing you have to take that as the baseline. The only predictors of AVN are one, age of, second, how far is the AVN away from the facial line, third, quality of reduction, and fourth, stability of fixation. Even your timing within 24 hours is good enough. It's not that you will get lesser AVN. So what is in the surgeon's hand is a perfect reduction and stable fixation to allow the head to revascularize. I think Melman and Moon's paper has demonstrated that age, something which is not in your hand, and the type of fracture, something which is not in your hand.
I'm sorry, Professor Sandeep, we cannot hear you. Your mic is not working. We prefer you to type in the questions.
Well, to supplement while Professor Sandeep is typing, I think I've repeated this over and over again. It really still is the quality of reduction. So I keep writing closed reduction plus or minus open. And I think our juniors and our residents are always very scared of open reduction in a child. Nothing to be scared of because, as Professor Sandeep says, it's actually most important. The quality of reduction and your fixation is most important. So if closed reduction doesn't work, then go for open reduction. You don't need to be worried about opening the hip joint in a young child. You just go for your lateral approach and you open the joint capsule anteriorly. And that is still by far the best predictor of reducing AVN. The capsulotomy, I say to myself and also to my residents, there's no harm done, but I wouldn't rely on the capsulotomy to reduce the AVN rate. Everything else is to facilitate it. But the most important factor, and it's the same, I'm sure Dr. Fang will agree, it's the same as in adults. It is your quality of your reduction. You have to have a good reduction. If closed reduction doesn't get you a perfect anatomical reduction, go for open. That's my message.
Okay, so I'll take one question from the chat.
So we have, Dr. Ayesha, we have about 7 minutes. You can ask more questions.
Okay, sure.
30 minutes for each speaker. Please go on.
So there's a question. So somebody is interested in knowing your technique for comminuted fracture, like in terms of reduction. What are your tips?
So comminuted fractures are tricky. They are usually at the base of neck or maybe intertrochanteric fractures. Again, it's like how you would treat the adults. So no smooth pins, obviously, because then they'll collapse. So you are looking more at more stable ways of fixation, such as screws or even locking plates. And yes, you have to span the length of the femoral neck, try to restore it as much as possible. And because they are so inherently stable, just cross the physis. Just put your screws in and cross the physis and use it as a fixation technique. I really don't mind limb length discrepancy. I can very easily treat limb length discrepancy. I cannot treat AVN non-union coxal. That's very much more difficult to treat. So for highly unstable fractures that are comminuted, adequate reduction, again, go for open reduction if you can't get it reduced in a closed manner, and then very stable fixation with screws or even locking plates.
Okay, so extending to the same question, would you always prefer a Jackson flat top or a fracture table when you're dealing with the neck or femur fractures?
I tend to use fracture tables. The traction table is good because I can reduce it as well as I do the reduction first. Maybe let's put it this way. I will place the patient on a traction table and try to do the closed reduction. And if I'm happy with the closed reduction, then I proceed. Then I drape the patient and I do my fixation. But if I'm not happy with it, then I put the tables back. Then I do the open reduction. So I have the traction table first, and I attempt the closed reduction. If it's unsatisfactory, then put everything back together and do an open.
Okay, and so there's a question regarding the difference between Delbert 1 and Skiffy. So I think that's quite a basic one, but of course, yeah.
No, it's a very important question, and I get asked this all the time. It really is the state of the physis and the mechanism of injury. In Skiffy, the physis is not normal. In Skiffy, there has something that has happened that has weakened the physis, and therefore low energy trauma can cause Skiffy. In fractured neck of femurs, the physis is normal. The physis is healthy, and you are putting it under a high energy trauma, and therefore it's that kind of trauma. And so the rates of AVN are obviously going to be much higher in a genuine traumatic neck of femur fracture versus a Skiffy, which is a sick physis, and a low energy trauma will cause displacement, which is why you have such a large spectrum of Skiffy. You can have the chronic Skiffy, the mild Skiffy, right, which is a sick physis and a very low energy trauma, and it gradually slips with time. And of course, the rates of AVN for those are very low. And then, of course, you have the other end of the spectrum, which is a little bit more like a neck of femur fracture, in which it's a very acute injury and it slips a lot. And again, the rate of AVN is quite high.
Yeah. I think that pretty much answers it for the person. So there was also a question regarding if you would prefer threaded pins or over smooth pins where you're trying to cross physis.
It depends on the size of the baby. So if it's a very, very small baby, just maybe under 5, you really can't put any meaningful screws in there. And also, when they're very cartilaginous, that's under 2 maybe. If they're very, very cartilaginous, there's no point in putting screws anyway, and you're just stuck with smooth pins. The size of the smooth pins, well, again, it depends on the size of the child, but probably a bare minimum would be a 2.0 millimeter K wire. Nothing smaller than that. It would be useless. Yeah. So thank you, Evelyn. That was quite an amazing, extensive review. We all learned.
Dr. Ayesha, one question was missed, I think.
Yes, you can please.
If you encounter lead displaced fractures, do you see that after that smooth pin question? So let me tell it for you, Dr. Evelyn. Yeah. The question was like that: if you encounter lead displaced fracture, he didn't say how much lead. How should a release be done to allow for better reduction of the leg length? I do not get it, but question was like that. So if you are asking me about late fractures in which you need soft tissue releases, then I assume it's a very late fracture, right? So any fractures that present within, say, a month or 2, you probably would not need any soft tissue dissection. But you think about the position or the direction in which the fracture typically displaces. So again, like adults, the fracture typically displaces because of the pull of the gluteus medius and also the iliopsoas, right? And so that's your typical position of
of displacement. Again, in my experience, maybe in Hong Kong, children are very well looked after. So we rarely get the very neglected fracture that requires soft tissue release. I find that in children in general, even if it's 3-4 months down the line, they don't have that much contracture to the point where you would have to do soft tissue releases. If you are getting a child who is so stuck down that you find that you can't reduce him and you are actually having to do soft tissue releases, then this is probably an older child and it's been neglected for a very long time. And if it's that situation, then you really have to start thinking to yourself, is it worthwhile really doing the reduction and the attempting of the fracture fixation? Or would you do something else, say, leave it out, like so it progresses to be a girdle stone, or at least just goes into non-union and then fix it later, or do an arthroplasty. If it's so late that you need soft tissue release, I'm thinking that you're probably looking at something that is more salvage than really still trying to attempt fracture fixation. I don't know about you, if anybody has any other opinions.
No opinion, then we'll go for the next paper. No comments, then?
No, I would just make one comment here.
Please.
Yeah, we have published in JBJS 2022 a review article on neglected fracture femur, and we have laid down some criteria after going through all literature. And we find that in situ fixation and a valgus osteotomy with or without a fibula stud graft, depending on how much bone stock is available on the neck side, is an excellent option for correcting limb length as well as getting healing. And even if AVN happens, you have a second chance to restore the head shape later on after the fracture. So for people who are interested in long delayed presentations or neglected fracture neck femur, I would recommend that you should go and read that paper.
Thank you, Sandeep. We will not go further with this thing. So, Dr. Ayesha, we can go for the next one.
Yes, we don't have any further questions. So,
yeah, Dr. Kyeong Park with ankle trauma and pitfalls, please.
So I was told this is a video session. I would be playing a video. Is that correct, our chairperson?
Yes, please.
Okay. Is the sound okay here?
Hello.
Yeah, we can hear you.
Okay, so I will.
Hello, nice to meet you. I'm Kyeong Hyeon Park from South Korea. I'll present a case-based presentation on the topic of common pitfalls in the treatment of pediatric ankle fractures. Pediatric ankle fractures account for 25 to 40% of all cross-plate fractures and are the second most common cross-plate fracture in children. It occurs mainly during sports activities and is an injury that the pediatric orthopedic surgeons often encounter. In this lecture, I would like to explain pitfalls commonly encountered in pediatric ankle fractures based on a case study. Pediatric ankle fractures can be classified using the Salter system for the PGL fractures. This classification is broadly consistent with treatment outcome and is widely used. The Diaz-Tachan classification system is also the most commonly used pediatric ankle fracture classification system. It presents an adaptation of a Lauge-Hansen classification used in adults. It is widely used as a useful classification to explain the mechanism of injury. Salter has type 1 or 2 fractures of distal tibia are extra-articular injuries caused by significant supination or pronation forces. Chloride reduction can be tried when these fractures are displaced. A residual gap more than 3 mm at the physis suggests entrapped periosteum, and it has been suggested open reduction to remove it may lower the rate of visual arrest from 60 to 17%. 8-year-old boy sustained a displaced pronation inversion external rotation fracture, and he underwent chloride reduction and the percutaneous pinning. However, there are a 3 mm gap on the medial aspect of distal tibia physis, which likely represented intrapt periosteum. The fracture was here, however, there was a close arrest at the medial physis of tibia with varus deformity. He underwent visual bar resection procedure. For fracture stabilization, smooth K wires across the physis or visual sparing screw fixation of a large metaphysial fragment should suffice. Any smooth wire across the physis should be removed at around 3 to 4 weeks, as this should allow adequate fracture healing. Once healed, these fractures are followed to screen for gross arrest. 11-year-old boy sustained a tibial physical fracture after trampoline. Radiograph shows Salter's type 2 fracture of tibia physis on the lateral view. Close reduction is typically obtained. The patient underwent close reduction and internal fixation using smooth K wires across the physis instead of physical sparing metaphysial screw fixation. The K wire was removed at 4 weeks post-operative in the clinic. At 10 months follow-up, there was a physical bar along the previous K wire pathway. Management of gross arrest is based on the remaining growth and may require further surgical treatment. Remember that the displaced fractures may stress the anterior soft tissue envelope. Caution needs to be exercised to diagnose and treat the so-called extensor retinaculum compartment syndrome, which may result. Treatment consists of release of the superior extensor retinaculum and the stabilization of the fracture. A medial malleolar fracture in children is a Salter's type 3 or 4 fracture, typically caused by supination inversion mechanism of injury. It is considered to be a high-risk fracture in children, as the fracture line propagates through the undulating foreland hump, the patophysis, with a high potential of visual growth disturbance. If truly undisplaced, which is uncommon, these fractures can be managed by immobilization and non-weight bearing for 4 to 6 weeks. 11-year-old girl sustained a supination inversion injury when she walking. There was a Salter has 3 fracture of the medial malleola. There was a minimum residual gap, less than 2 mm. So the fracture was treated with closed reduction and cast immobilization. At 10 months follow-up, symmetric Parker Harris line parallel to the physis indicates a normal growth. When displaced with the articular step up or more than 2 mm residual gap, anatomical reduction and internal fixation should be performed with the goal of restoration of articular congruity and anatomical alignment of the physis. Surgical fixation has been associated with a lower rate of visual arrest compared with close reduction alone. If close reduction is achieved, percutaneous fixation of the fracture can often be performed. The preferred method for hardware placement is 1 or 2 partially threaded 4 mm cantilever screws parallel to the physis. The transverse intraepiphyseal screws. A 12-year-old girl sustained a supination inversion injury when she fell from the stairs. There was a Salter's type 3 fracture of the tibia physis. The fracture was treated with close reduction and percutaneous K-wire fixation. The K-wire was removed at 4 weeks post-operatively. At 10 months follow-up, she had a facial medial growth arrest with progressive varus deformity, so the valgus corrective osteotomy was performed. If possible, transvisual fixation should be avoided, and the progressive ankle varus, these fractures has to be followed until normal growth of the physis is ascertained. An incomplete or oblique Parker-Harris line would indicate fascial growth arrest. Salter's type 3 fracture of tibia physis occurred in a 9-year-old boy a residual gap, and the medial the impaction fragment were confirmed on CT. However, percutaneous screw fixation was performed. Post-operative imaging shows that the anatomical reduction was not achieved. The physical arrest occurred at a 2-year follow-up. 11-year-old girl sustained an ankle inversion injury. The radiograph shows Surtees type 3 fracture of the tibial physis and the Surtees type 2 fracture of the fibula physis. Although it is not clear on X-ray, a medial impaction fracture is confirmed on CT. In the case of inversion injury, medial impaction is not uncommon, so the CT scanning is useful to detect these injuries. Off reduction of the infection fracture was performed. The satisfactory reduction was confirmed in the post-operative CT images, and the screw was removed after union. The common method of tension band fixation in adults or transfixial fixation is not an appropriate form of the treatment of these fractures because of the potential of fascial growth arrest and the resultant progressive ankle varus. These fractures has to be followed until normal growth of the physis is ascertained. An incomplete oblique, the Parkinson line, would indicate the fascial growth arrest. The management of fascial growth arrest is based on the amount of the deformity and the remaining growth, and may require further surgical treatment, including fissure by excision, epiphysiodesis, and or osteotomy. The presence of distal tibia and the fibula physis in children leads to unique fracture characteristics and the complications that differentiated these fractures from others. Transitional fractures occur during adolescence as the physis transition to close in an asymmetric but consistent fashion. The juvenile T-lobe fracture is a Surtees type 3 fracture through the unfused anterolateral part of the distal tibial physis. When clinically suspected based on the pain or swelling around the ankle, careful evaluation of the multi-view radiograph could reveal the vertical fracture line from the physis into the epiphysis. CT scan better defines the fracture displacement, can aid in surgical planning. When displaced more than 2 mm, the fracture should be treated with an anatomical reduction and internal fixation using 1 or 2 threaded cannulated screws. The reduction can be achieved via open or closed method. During percutaneous fixation, it is easier to introduce a guide fin from lateral to medial, starting just anterior to the palpable distal fibula. The screw can be inserted across the physis as growth arrest is usually not a major concern at this age. Surgery can be performed with percutaneous fixation or arthroscopic assistance. When performing percutaneous screw fixation, the superficial peroneal nerve should be protected. For most T-lobe fractures, screw fixation is sufficient. However, the fragment is small or there is a risk of crack. The mini-flat or Kyeong Hyeon fixation shows good results without complications. T-frame fractures are also transitional fractures, but the fracture configuration could be confusing as the fracture line propagates through 3 separated planes. It is a true Surtees type 4 fractures, but appears like a type 3 fracture on the AP view and a type 2 fracture on the lateral view. Various subtypes of the T-frame fractures have been described based on either number of the part, joint involvement, or side of involvement. CT scan is recommended to assess the fracture configuration and help in surgical planning. For displaced intra-articular T-frame fracture, anatomical reduction and internal fixation using screws or KY should be performed. During internal fixation, the intra-articular part of the fracture could be stabilized similar to a T-lobe fractures. A 14-year-old male sustained a triplan fracture of distal tibia and the fibula fracture. The radiograph shows a Surtees type 3 fracture of the tibial physis on the AP view and type 2 fracture on the lateral view. The CT scan reveals the displacement of the plan of the fracture that would help in surgical planning. Open reduction and internal fixation was performed using the cannulated screws in the epiphysis and the metaphysis. The trajectory of which is typically perpendicular to each other. The final follow-up radiograph shows a healed fracture with retained hardware. 12-year-old girl fractured her tibia while suffering. Although it was not clearly visible on the radiograph, a trifling fracture was confirmed on the CT image with the fracture line extending to the ankle. Therefore, a prophylactic screw was fixed to prevent further displacement. When there is a tibia spiral or oblique fracture, it is reasonable to suspect an ankle fissure fracture. Isolated distal fibular fracture are Salter's type 1 or 2 fractures caused by low-grade inversion injuries, similar to lateral ankle sprain in adults. They are commonly treated by 3 or 4 weeks of immobilization. Treatment is not difficult, but it is important not to miss the diagnosis. Typically, displaced fibular fractures that accompany tibial fissure fractures do not require internal fixation. However, in high-grade injuries, internal fixation of the fibula may add to the stability of tibial fracture fixation. An 8-year-old girl was diagnosed with fibula Salter type 1 in a car accident. Percutaneous pinning and the cast was applied to the fibula fracture. The pin was removed 3 months later, and the fibula shortening with hindu-foot valgus occurred due to fibula growth arrest at 2-year follow-up. When fixing a pin that crossed through the physis, inserting a thin, smooth pin and removing it within 4 weeks is a way to prevent complications. A 5-year-old girl sustained ankle sprain. The radiograph shows normal. After 2 months follow-up, she complained of lateral ankle pain. Still, the X-ray shows no abnormal finding. Distal fibular avulsion fracture non-union was diagnosed as 3 months follow-up imaging. If tenderness or swelling persists in a pediatric ankle injury, careful examination is necessary to avoid missing a diagnosis. When pain occurs after an injury to the lateral aspect of ankle, not only fibular fracture but also other fractures should be suspected. 2 injuries that should not be overlooked during the management of the distal fibular fractures are osteochondral fracture of the lateral taladome and lateral process fracture of the talus. In summary, in Salter type 1 or 2 fractures of distal tibia, if there is a widening of more than 3 mm, open reduction should be performed. For medial malleolar fissure fracture, anatomical reduction and fixation parallel to the physis is recommended for transitional fractures. CT is useful for accurate surgical planning, and if there is a displacement more than 2 mm, treatment is necessary. In Salter's type 1 or 2 fractures, if there is a delay of more than 5 days, waiting for further remodeling can prevent further cross-plate damage. The top 5 pitfalls. For displaced intra-articular fractures, Salter 3 or 4, the transitional, like that, the close reduction alone is not acceptable treatment. Surgical stabilization decreases the rate of growth arrest. Respect the physis and avoid rigid or permanent hardware across the physis. And do not miss the intra-articular transitional fractures or talar injuries that can accompany pediatric fissure fractures. Be aware of extensor retinaculum compartment. Follow patient till normal fissure growth is established, or possibly until skeleton maturity. Thank you.
So, thank you, Dr. Park.
Thank you.
We have a few questions here. Most of the KOS crossing physis leading to physeal arrest So will you recommend not to do it, Dr. Park? Someone asked from the audience.
Thank you for the question. When I work in my clinic, many times I meet the cases which is the cost of physics. So my recommendation is that if you fix without crossing the physis, you can use the screws or just the K-wire. But in some times, very high energy, after fixing the screws, there is some instability. At that time, you can use the smooth K-wire, the crossing pin, but you should be remove it earlier. And now I use the mini plate, which is saving the physis above the physis and below the physis. If you can use the small locking plate or like that, you can save your physis. So my recommendation is that if possible, you can save your physis. And sometimes the mini locking plate is useful. That's my question. That's my answer. Yeah.
Thank you, Dr. Park. But one question, we know that if we remove it early by 3 to 4 weeks, it usually will not cause this type of fascial arrest. So any other say, because sometimes we need to give smooth pins and even crossing the physis. So any other way that we can prevent, apart from that removing earlier, any other way we can avoid these fascial injuries?
I think the most important thing is the anatomical reduction. Everybody agree with that. After that, some smooth pin. In case I'll already remove the K-wire, I will keep the cast more time. So yes, yeah. In some cases, you must use the smooth pin to close the physis, but always the warning or explain the parents there can be a fissure bar. So the long time follow-up is needed, I think.
Thank you, Dr. Sandeep. Any other tips regarding avoiding this fascial arrest with smooth pin, apart from removing it earlier? Anything else you would tell us?
If the fracture is not intra-articular, I would be happy accepting a suboptimal reduction as long as I don't have to dissect into the physis too much. Remodeling and healing is very quick in such injuries. Unless it is intra-articular, where it is important to restore the articular congruity, I might accept a suboptimal reduction. And if I put a pin, I aim for the center rather than periphery, because then I don't, even if there is an arrest, usually there won't be a coronal plane deformity. And remove the pin as early as possible, because fascial injuries come up very fast. So you could remove the pin in 3 weeks and carry on with the plaster for 6 more weeks if you want. But don't leave hardware in for too long across the physis.
One more question. Yes, Dr. Ayesha, you want to say something?
Yeah, so I just wanted to make a comment here. Of course, fascial injury can be secondary to our attempts at reduction, or maybe after crossing even smooth pins. But some of it is inherently because of the nature of the injury itself. So probably if we start counseling the patients right away from the pre-operative time, that there is there's a higher risk to kind of an arrest happening, then we would not really be blaming our wires for this particular situation.
Just 1 minute. Just another comment there, Ayesha. So type 1 and type 2 have very low incidence of growth arrest. If you try to pass pins in those, then you're definitely going to cause more harm than any good. The type 3 and type 4, I agree, are already high energy injuries, and articular component and fascial component needs to be put as perfect as possible. But we've seen people reacting to fascial injury, even type 1 and type 2, and they try to pin it. That is where I was saying that I would accept a little displacement, because those are low energy and they will not cause an arrest. Rather than if you put pins there, then you are definitely culpable.
One more tip could be, I think, Sandeep, if you say like this, we are used to put the keywords in perfect position. So do not take many chances. Just
exactly.
one single
Repeated attempts is not a good idea.
Repeated attempts we can avoid.
And use a low energy tool. Sometimes in younger children, a T handle K-wire is good enough. You don't even need a drill. So.
Well, the next question is from the audience: are syndesmotic injuries common for children? If they occur, how to deal with them? Dr. Park.
Yes, thank you. Good question. But the more younger patient, about 5 years, 6 years, I think is usually lower trauma, lower age trauma injury. So it's very rare injury. But in the older children, like 10 or more, in that case, I usually check the CT scan with the bilateral ankle. So if there's some displacement or suspicion of syndesmotic injury, I check the Shyam. If there's instability or severe syndesmotic injury, I use the screw fixation, or the K-wire, and plus the more longer immobilization.
Thank you. We have. I'll take it as the last question because we don't have much time. We have to go back to the chairman. Last question would be for conservatively treated fractures. Is a removable ear cast is as good as a complete plaster cast?
Yes, that's the good question. But the main problem is the compliance in younger children. I cannot believe the child. I'm sorry. So I prefer use the cast is the best option for the children. I think at least 6 or 8 weeks. After that, you can use the if there is some callus formation and some tendons is decreasing, you can use the removable air cast, I think. So I use the cast.
Okay, thank you. If no more comments or questions from any side, I'll go back to chairman of this session. Any questions, please, or comments? We can see beautiful things happening there with Dr. Evelyn Kuong.
I'm terribly sorry. I'm really sorry.
That's beautiful. That's the beauty of Zoom meeting, Evelyn. So I go back to Dr. Kaji Shahid-ul, the chairman of the session. Thank you.
Thank you, everyone. I am first very much grateful to our audience, which are not visible to us, but they are always with us and encouraging us with all these beautiful questions. I hope this session has benefited them, for which all the sessions are targeted as. And next, I will congratulate all our speakers for their effort and all the informations. I will congratulate both our moderators to conduct the sessions very nicely. And now I would ask our president, Dr. Anup Agrawal, sir, to wrap up the session. Dr. Anup, sir.
Yeah. So thank you, everyone. I think it was a wonderful learning process through APOA trauma. Let me say thank to Christian Fang and Ayesha Saeed for bringing up with such a nice academic session. And I'm sure delegates must have been benefited by this. So thank you, every faculty, for coming up with wonderful talks, a good learning process, sharing knowledge and learning from each other. Thank you. We'll sure have more series of like this in the coming months, and Christian is there who is going to organize all such meetings further. Once again, thank you. Over to you, Christian.
Yes, thank you. Thank you for the excellent faculty, excellent discussions, excellent presentation. I just want to note that all these are recorded and will be preserved and will be made available in the APOA website. So you can ask your peers to go and revise them later on. Again, thank you very much, everyone.
So bye-bye. Thank you very much.
Bye-bye.
Thank you, everyone.
Bye-bye.
Thank you.
Bye-bye. Thank you.
Bye-bye.
Bye-bye, little children.
Recording stopped. you.